Hi, my name is Haley, and today I'm going to provide you with a quick overview of the measles virus. So we're going to start with a quick description of the virus and how it spreads, its evolutionary history, the disparities found throughout the world, what is projected to occur, and public health initiatives to reduce the risk. So in this section, we'll describe what measles is, its mechanism of contraction, its symptoms, and the physiological processes involved. So what exactly is measles? Well, it's an acute respiratory illness caused by an RNA virus. This virus has 6 structural proteins, with the key protein of interest being hemagglutinin, as it allows for attachment within the host. There are also 2 non-structural proteins that cause immune suppression. So while it has essentially been eliminated in the United States since 2000, it has risen slightly from 37 cases in 2004 to 1,282 cases in 2019. This is due to a large number of factors that will be touched on a little bit later in this video. Measles is non-zoonotic. Essentially, it can only be passed between human hosts. It has a high transmission rate with an RO of 12 to 18, meaning if one infected person walked into a room with 100 non-immune individuals, 90 of them would get it. So the virus lives within the nose and throat mucus and is released when another person coughs or sneezes. The virus can live in the air for a number of hours, thus it spreads when another person breathes in that contaminated air or touches a contaminated surface. A person is infectious for around 8 days. So if a person is unvaccinated, travels internationally, or has a vitamin A deficiency, they are much more likely to contract measles. Measles symptoms to look out for include short-term symptoms such as a cough, runny nose, fever, sore throat, inflamed eyes, Koplik spots, and skin rash. So these symptoms are not only the body's way of fighting the virus, but it can also aid in transmission to others. Long-term symptoms include immune suppression, and this makes individuals susceptible to secondary diseases for up to 2 years. So the physiological processes include entry, dissemination, transmission, and immune suppression. So the virus enters the body due to attachment of that hemagglutinin protein to the P65 subunit. The key cells here include the CD150 plus cells in the alveolar spaces, dendritic cells in the respiratory tract, and myeloid or lymphoid cells in the conjunctiva. So for dissemination, these cells then migrate to the draining lymph nodes where the virus is transmitted via cell-to-cell transmission to CD150 plus lymphocytes. This virus is then carried to the organs where it is amplified. So for transmission, the virus, attached to those dendritic cells and lymphocytes, transfers the virus to the epithelial cells in the respiratory tract. This causes the coughing and sneezing that outputs the virus into the air, where it can survive for hours, allowing for transmission to new hosts. Lastly, immune suppression is caused as interferon production is halted. This immune amnesia increases susceptibility to secondary diseases. However, lifelong immunity to measles is also garnered with specific IgG antibodies produced to prevent that hemagglutinin attachment. So in this next section, I will discuss the divergence of measles and its current evolution. So the divergence of the measles virus is actually greatly contested by researchers. So current researchers on the lung featured to the right has actually did a divergence around the 6th century BCE. So this is the earliest it could have occurred, as cities were growing and connecting, leading to a large enough human populace. However, others believe that there is a 9th century or even 11th to 12th century divergence with prior recording of similar symptoms due to ancestor strains. So the common assumption is that the virus diverged from the rinderpest virus due to spillover from cattle to humans. This can be seen in the little graph on the right. So currently, there are as many as 24 different genotypes of measles split due to geographic region. So despite these minor differences, much of the proteins are actually conserved with little changes to vaccine efficacy. However, many of the genotypes do have a higher transmissibility to those who are not immune, and vaccinations are not a failsafe. This is highlighted by Measles Mary, who was a woman who received both doses of the measles vaccine, but lost the antibodies over time to a negligible amount. So she caught and transmitted the virus to a number of people, some who were vaccinated and lost all of their antibodies, and some who were unvaccinated. Thus, it is important to track that efficacy over time and recommend boosters for those at risk. So in this section, I will define the disparities between nations, within nations, and the effect the pandemic had on the measles virus. There are a number of disparities both between nations and within nations that were further strained by the pandemic. When looking at the immunization rates for the 2 doses of vaccines, the average immunization rate is 83.12% and 76.36% respectively. The lowest are relatively low-income countries with weaker healthcare systems, which is attributed to some of the highest death rates. These countries can't always afford the vaccine, nor do they have the infrastructure to distribute it across the country. As in sub-Saharan Africa, there is little access to care around borders, as well as a fear of vaccination due to the lack of education on the benefits and risks. Additionally, there are issues with the vaccinations in areas of high disruption, such as in the Ukraine. While it may initially be surprising that a wealthy country such as the United States is slightly below that herd immunity level, there is a huge fear of vaccines and their risks due to poor outreach with society, as well as language and monetary barriers. Disparities within Ecuador further highlight the difference in social classes, with many more vaccinated and higher socioeconomic groups. Lastly, the pandemic greatly exacerbated the current disparities, with 23 million people missing out on the vaccine in 2020. This led to a drastic increase in the number of measles cases worldwide, especially as social distancing and masking decreased in their use. In this section, I will quickly run through prior models of the measles virus with their predictions for 2050 and 2100, and then run through my own models and their limitations. As a quick note, modeling is a simplistic prediction based on current available inputs and educated assumptions. No model is perfect, nor does it claim to be. This being said, each of the following models, including my own, show the importance of vaccinating against measles to not only eradicate measles in other countries, but to continue eradication of measles in our own. So in the first model, run by Han Fu, it demonstrated that the first dose only reduced measles cases by 66%, while the second dose brought it up to 90%. Winter further highlighted their importance by showing increased rates would decrease measles-related deaths to nearly zero by 2100. Depending on the two models used, 16% or 39% of countries had a 75% chance or higher of measles elimination by 2050. Lastly, Trentini highlighted this shocking issue with the current vaccination rates. By 2050, only Singapore and South Korea would have the eliminated status unless new policies were put in place. This is backed up, in part, by the resurgence of measles, where there is a close call of elimination loss in 2019 in the United States. In SimPandemic, I modeled measles over a year-long period with 100,000 people based on available vaccination rates. In the United States, there are only 2 deaths and 30 hospitalizations, with nearly all reaching immunity by the end of the model. Only 2,500 were infected. This is in stark contrast to the Ethiopian model, where there were 798 deaths, 2,535 hospitalizations, and nearly 60,000 infected. They too reached nearly 100% immunity by the end of the model. I also ran a model in melting asphalt. In this, there is no immunization rate, meaning the entire population was infected. This being said, vaccination effect could be seen slightly via the death rate, as the United States has a much lower measles-related death due to higher vaccination rates. Only 2% died in the United States compared to the 48% in the Ethiopian model. While both did show the effect of vaccination, leading to the determination that higher rates are better, SimPandemic was a better option to show the true effects. This being said, it is a much harder model to use as it has more parameters and it is not quite as easy to visualize as the melting asphalt version. No matter the case, it is important to understand the limitations of each model. In this final section, I will define global initiatives and then narrow in on the initiatives in the United States and Africa. There are a number of public health initiatives designed to decrease measles risk. While some researchers have suggested a so-called no jab, no school policy, there are worries about personal freedoms here. Thus, the following initiatives are designed more for increasing the rates of both doses to at least 95% in other ways. So globally, there is a push for increased education, increased supply, improved distribution, and decreased pricing, particularly for middle-income countries who often pay the most. In the United States in particular, there is a desire to reduce misinformation, increase supply to areas that currently are lacking, and increase the number of vaccinations for international travel so people are not bringing measles back to the country. Lastly, in African countries, there is a desire to not only increase vaccination rates, but also to increase surveillance to ensure the true number is being recorded. To increase the vaccination rates, there is a desire to increase the supply to rural areas with the help of volunteers and employ local leaders in educating the general public on the safety of vaccines. To decrease measles in general, they want to screen for risk factors such as vitamin A deficiency and combat these as well. Thank you for listening to this brief presentation on measles. If you have any questions, feel free to reach out and I will be happy to answer. Lastly, here are the sources that I used. This is the first half from 1 to 28, and this is the second half from 29 to 55.